Hello, everyone. Welcome to the session on Alzheimer's disease, where we'll talk about the importance of early detection and collaborative care. I'm Carolyn Clevenger. I'm a professor and associate dean at the Nell Hudson Woodruff School of Nursing at Emory University in Atlanta, and more relevant, the clinical director and one of the nurse practitioners in a practice called Integrated Memory Care at Emory Healthcare.
And I'm David Geldmacher. I'm the Warren Family Endowed Chair in Neurology in the Department of Neurology at UAB in Birmingham, Alabama.
These are both of our disclosures. You can see some research and consulting support. And we have been informed of our responsibility around off-label discussions, and this has been independently reviewed for balance. So today's learning objectives, there are four. We want to talk about some of the strategies to ensure that early recognition and diagnosis of Alzheimer's disease. We'll talk about the currently available therapies and some agents in late-stage development, and then finally talk about collaborative care strategies so that people have optimal management plans who are living with Alzheimer's disease. And this is our agenda. We'll cover this in 4 sections. I'll begin with a case and the primary care role, which is my clinical role, and then I'll pass it over to Dr. Geldmacher, who will talk about some of the treatments. So first we'll begin with the case. This is a patient who was new to my practice just a few weeks ago. She's 78 years old. She's a retired nurse, which I always enjoy when they come to see a nurse practitioner clinic. And she had been engaging in primary care pretty frequently south of the city. So she had been seeing them because of some significant weight loss and some anemia. She also has 3 daughters, one of which is a nurse colleague of mine. So they were really concerned about this. Now, she also saw cardiology, so a specialist practice as well for her atrial fibrillation, was on appropriate rate control and anticoagulation for that. With her weight loss, she had been referred over to oncology and probably with the hematology consult as well. And they were really having a hard time figuring out any source of this weight loss that was pathological. Her family had noticed some short-term memory loss for years and said that she was doing a lot less cooking. Her husband also had some pretty significant chronic illness recently before she came to see me, had a below-the-knee amputation, and was also undergoing ongoing treatment for some chronic hematological disorders himself. And she had been doing just less care around the home. She didn't really feel like, she wasn't keeping up with laundry and sort of some minor things that the family would call more like insidious and sort of not really sure what was going on with her. And things came to a head when the cancer center where her husband was getting his treatments, he would go for day-long visits during which he would get infusions, and she had not picked him up. And when they called her, she said to them, I tried to pick him up. It's not that she forgot about him, but she was driving around town, and they're in a small town. The family emphasized to me, this is not driving around Atlanta and not able to find the cancer center. In their small town, she was not able to locate the cancer center, and so eventually just drove back home and thought someone will just have to call me because I can't remember how to get there. So this is someone who had been having cognitive changes, had not necessarily been evaluated for those changes. And honestly, as it turned out, her weight loss was due to the fact that she was having such executive dysfunction. She wasn't cooking. She and her husband were not eating. So I think she's a nice example of someone who is engaging with the healthcare system and is having some cognitive and functional changes and not necessarily getting this diagnostic evaluation and workup that we'll talk about today. So I just want to remind all of us, and this probably goes without saying in a primary care audience, the role of primary care is so critical in our healthcare system. If you think about healthcare as a house or a home, primary care is the front door, it's the entryway. It's many times, we hope, people's first contact, and that level of accessibility, in particular in some of the advanced primary care models that are called out specifically, right? 24/7 availability in some form or fashion. It integrates the whole person. This is where we say we're not focused on one body system. We're looking at you overall. It's actually the perfect place for something like unintentional weight loss initially. That we sort of play the coordinator or the quarterback in terms of integrating other services and specialists that are involved in this person's care. And because primary care is so much about the relationship over time, we have this established ongoing rapport and can have more sensitive and critical conversations with both patients and their families because of that rapport and foundation that we've built. So what a critical place then for someone who's experiencing cognitive, and I put this in air quotes for a reason, symptoms to come and to have something like that evaluated. So the thing about a cognitive symptom, so in our medical practices, someone presents with a symptom and we follow a standard process to evaluate that symptom. And for some reason, in the case of cognitive symptoms, it doesn't happen reliably, but there are some good reasons for why that is. Sometimes they're very insidious, right? So unintentional weight loss doesn't necessarily translate to us as a cognitive symptom. So symptoms are not just about having problems with memory or having problems finding words, which you might observe and the person may or may not be aware of. In fact, all of their cognitive symptoms may or may not come with a level of awareness by the patient themselves. Sometimes the symptoms are not so much cognitive, but they're behavioral. So there's a lack of inhibition. There are overutilization kind of behaviors, things that are just different. They're kind of hard to put your finger on exactly. Potentially it's early hallucinations, or maybe the symptoms are functional. They're changes in especially their instrumental activities of daily living. And if we're not doing assessments on activities of daily living by the person or an informant on a standard basis, you certainly can miss that many times in primary care because you're still in an office setting. And true functional observer rating comes from seeing someone in day-to-day life, hence the name daily living. And the other component to this is that the source is not necessarily the patient. It may be, in many cases, it may be the patient saying to you, I'm having these concerns, I'm noticing these changes. But it also might be what I will call an informant. So an informant is, in my world, what I would call someone who is not a caregiver, because the person doesn't require care to be given to them, may not even be a care partner, where the person needs someone to partner with them in terms of their day-to-day life, but it's someone who does observe them. This could be a family member, a spouse, an adult child, it could be a neighbor. And sometimes it doesn't happen in the visit, it's in advance of the visit. You probably have had circumstances where a spouse or an adult child has called your practice in advance of a visit saying, you know, my dad's coming in for a visit and I want you to know we're seeing these changes. You could get this source of information as a formal relationship. It may be their employer who's noticing them. It may be law enforcement who has observed these behaviors or cognitive changes. It may be you, it may be your front desk staff. If you schedule your own appointments, in my practice, where we do that, our patient care coordinator who schedules for us can absolutely tell you that the patient themselves is having cognitive issues because of the interaction they're having on the phone. So a little different. But when completed, the diagnosis does typically occur within primary care. The vast majority of Alzheimer's disease diagnoses are made there. Now, in my state of Georgia, one of our Georgia Alzheimer's and related disorders surveys took a look at an annual call to older Georgians. Almost 400,000 of them self-reported cognitive symptoms. I know we always kind of think about in primary care, well, many people aren't coming forward. These people did, but the vast majority had not discussed them with their primary care provider. So they believe they're having cognitive symptoms when asked, but they didn't bring it up to primary care during a visit. And when they don't do that, and we don't ask, their results in this particular year showed an average of a 6-year delay in dementia diagnoses. And I will just tell you that delay is longer in people who are in the non-white population, are Hispanic or Black older adults. But there's a lot of value in doing that evaluation and diagnosis. I know in worlds where things are more acute, like stroke, we think about time equals brain. In the world of dementia syndrome, time equals both brain and livelihood. So there are both biological reasons for doing an early diagnosis and intervention, and there are their ability to maintain their livelihood over time. So the therapeutic need, obviously we want to optimize their vascular condition. We want to put all healthy things around those neurons that are remaining. And most of the time, any clinical trial opportunity is available only to people very early in their disease stage. But it also has these other components. So if their behavioral or functional or cognitive symptoms create discord within their marriage and they end up getting divorced and then find out they actually had a dementia syndrome causing that sort of change, that's a major loss to their support network. If they have then poor relationships with their adult children because of these symptoms, again, we need that support network around them going forward. If they run into encounters with law enforcement that are due to their behavioral symptoms of their dementia, and they don't have a diagnosis of dementia, it's very difficult to explain why they would have behaved the way they behaved in the cell phone store, as one of my patients recently did. And of course, we know for a long time, early in the disease maximizes their ability to participate in future planning. There's some things that we know, though, about this continuum of Alzheimer's disease specifically, and that is that by the time people present with symptoms, there has been years of pathology building in the brain before even those mild cognitive impairment symptoms, and certainly before the syndrome of dementia. So we understand these in different phases now. And this is sort of a high-level schematic of what that looks like. This long period of preclinical opportunity, and then mild cognitive impairment where you start to see decline, and then obviously dementia being more significant. And that timing coincides with biomarker changes now as well. So you can see during the phase on this x-axis, well, that preclinical phase that we saw previously, so cognitively normal. If we were doing our exams in terms of neuropsych testing and other office-based exams, they would appear cognitively normal. They would do perfectly. And as those biomarkers, as the amyloid and the tau begin to increase, you start to see changes in MCI. But look, by the time we're at dementia, there's a fair amount of leveling off by this phase. So this surge is happening during the time that they're in cognitively normal and just before mild cognitive impairment, but very, very much you can see changes continuing to happen in that MCI phase. Again, this is fairly high level. But if you overlay those two on one another, you can see, again, we're looking on the x-axis as the cognitively normal time to then MCI and then progressing to dementia. So these opportunities as that amyloid and amyloid is increasing, that's very much during that cognitively normal stage, and there's this opportunity then to make a difference because the cognitive symptoms are delayed. They follow the buildup of the amyloid. So what does it mean then to arrive at that complete diagnosis in the primary care setting? So these neurocognitive disorders, in terms of our DSM-5 criteria, are made up of 5 criteria and 2 specifics. So there is either minor or major, and we would have said this is minor neurocognitive disorder. We would have referred to that as mild cognitive impairment. Major, we would call that dementia syndrome. So that one of those 2 should be distinguished. There should be, if at all possible, a probable underlying pathology, whether that's Alzheimer's disease, Lewy body, or so forth. What stage they're in at this point, early, moderate, late. We can be a little more specific in our clinic. We talk about early, moderate, and late moderate, and with or without behavioral symptoms. So complete diagnosis in someone's medical record should say minor neurocognitive disorders, probable Alzheimer's disease, and at that point, you're not staging because it's minor or mild cognitive impairment. This is kind of the schematic that I think about in terms of getting to that diagnosis. So someone presents, so from top to bottom, someone presents or you are informed of a cognitive, behavioral, or functional symptom. The magic of the diagnostic evaluation occurs in there. You establish whether it's minor or major, the probable underlying cause, and with or without behavioral disturbance. And as a reminder, the way we distinguish mild cognitive impairment from dementia syndrome or a major neurocognitive disorder is that you begin with an objective cognitive impairment in one of the domains, maybe it's multi-domain, and if they have functional dependence, so some loss of their full independence to maintain day-to-day life, and their most likely instrumental activities of daily living will be impaired first. When that occurs, that is the distinguishing factor between minor versus major. As a high-level overview of some of our recently published guidelines on how we arrive there, again, if someone presents with symptoms, this is the magic of the diagnostic evaluation in your previous schematic. We're going to begin with our history of present illness, but with an emphasis on our cognitive domains and carefully looking at what's potentially contributing. In particular, I think about medications and cholinergic burden, and I think about substance use, which I think we're not necessarily as aggressively assessing as we should be with older people. You should use a validated tool for function, so IADLs and ADLs, and a validated tool for neuropsych symptoms. Just a word to you, most of those validated tools are validated with observer reports. So you will actually need that informant to support that. You would do your neuro-focused exam, your basic labs, nothing fancy, and maybe the addition of thyroid function tests and B12, and then structured imaging. These are the things we do for most people. You can be more specific in terms of neuropsych testing. So not everyone can do neuropsych testing. If I have someone who hasn't driven in 10 years and their family's been managing their affairs and they are requiring assistance with toileting, they may not be able to participate in neuropsych testing. And then as you go through those guidelines, they become increasingly less frequent. This is more a question of if things are still unclear, then you may do these. And you're most likely talking about a dementia specialist level of care at these points. These are some of the common cognitive tests you might try in primary care, both informant or care partner informed or patient. MoCA is one I think people use very frequently. That's the one we use sort of as our mainstay. And you can see some of the differences in the time it takes to administer. And I'll pass it over.
So I'll pick up here and begin to speak about the response after that diagnostic workup that Dr. Clevenger described with the medications that are currently available and some look to the near-term future of available treatments, perhaps that we'll have in the next several years. Our mainstay for treatment of people with Alzheimer's disease since 1996 have been the cholinesterase inhibitor drugs. They've demonstrated efficacy in mild and moderate Alzheimer's disease as well as severe AD. There are 3 currently available: donepezil, galantamine, and rivastigmine. There are no overall differences in efficacy between them. The average response to treatment is a delay of decline. And as the graphic here illustrates, people who begin treatment later have a overall worse course than those who begin earlier. And the benefits of the early start are detectable through 3 years of treatment. Safety and tolerability is always a concern, especially in the primary care setting. And when we look at the package labels for these agents, we can see some pretty scary things. But in the community setting, about 1 in 7, about 14% of cholinesterase inhibitor patients report adverse effects over the first 9 months of treatment. 2 of our current treatments, rivastigmine transdermal and donepezil 23 milligram, were not included in this study. They were not yet available. If we look at double-blind placebo-controlled trials, the numbers are much higher: nausea, vomiting, and diarrhea, all at rates higher than that community report. The reason for that was most occurred during initiation of treatment or dose titration, and the current scheme of escalation of dosing and the timing of that had not yet been established. So we were frequently forced to increase doses in people who were having minor symptoms and then have more major symptoms. Something that wasn't captured well in the initial clinical trials but has become noticeable is the rate of syncope, and its complications are 1 to 2 times higher than in the placebo control, and these can be significant and meaningful, mostly due to bradycardia from the direct cholinergic effect of the drugs. Adverse events are associated with dose. Higher doses have higher rates of adverse events, and the more slowly we increase dosing in the cholinesterase inhibitors, the fewer side effects will emerge. Memantine is our other agent. It follows a different class of mechanism of action. It's an NMDA receptor antagonist, and it was approved for moderate and severe AD. It's frequently used in more mild cases, but that's off-label. The FDA approval is for moderate and severe. As we see here in measuring the severe impairment battery in this group of moderate and severe patients, memantine delayed decline, and that period of delay is evident for 6 months, but by the end of 1 year, early start versus late start were not significantly different. So it appears that the duration of memantine's efficacy perhaps is somewhat less than the duration of the cholinesterase inhibitor efficacy. They are frequently used in combination. Here in this graphic, the orange lines are memantine plus donepezil, and the gray line is donepezil alone. And so we can see that the combination therapy through 6 months, which is the longest controlled observation, shows benefit for the combination relative to donepezil alone. So a quick summary of those current treatments, and they're often misunderstood. They are neurotransmitter therapies, and they help brain cells work better. They do not improve the symptom of memory in most people. However, they do delay worsening of memory and function. They do help to maintain personal independence, and they do reduce caregiver burden, for instance, in behavioral symptoms and care spent in, or time spent in care. These medicines do not restore brain cells, nor do they help them live longer. They are not attacking the mechanisms of Alzheimer's disease that lead to brain cell death. They do not reverse or remove any accumulations of amyloid. So in the paradigm of pneumonia, they're treating the fever, they're treating the symptom that results from the illness, but they're not treating the core features of the illness like the bacteria in a pneumonia. Behavioral symptoms are common and frequently, as Dr. Clevenger has pointed out, the presenting symptom, agitation, irritability, sleep cycle disturbance are often early symptoms. And so I ask, just for rhetorical purposes, what's the best evidence for treatment of behavioral symptoms? And there are several options. We could say there are well-supported evidence-based guidelines. Antipsychotics work well, but they're risky, or that there's specific treatment approaches that are generally not supported by high-grade evidence. And unfortunately, number 3 is the correct answer. We don't have high-grade evidence for any specific therapies. So when I talk about treatment of behavioral symptoms with pharmacology, these will all be off-label uses. So agitation is a very common complaint, but it comes from many different sources. And in any one person, there may be multiple sources. So we can't take a uniform, prescribe this drug for agitation approach to this. It requires some of that careful history taking. What are the triggers for the agitation? And what is the context in which it arises? And in that situation, then, we can pick a specific agent or non-pharmacologic approach to the behavioral symptoms. If we continue with non-psychotic agitation as perhaps one of the most common types of behavioral symptom in Alzheimer's disease, we do have some guidance from double-blind placebo-controlled trials. Citalopram is best supported by clinical trial data. As you can see in the graphic, the group on citalopram had lower rates of agitation than the group on placebo in the course of this clinical trial. However, it's not an elimination of agitation. It is a reduction in severity. And so no drug works in isolation for this, and a combination of behavioral and pharmacologic approaches work best for most people. There are some safety concerns as we get to higher doses. In this particular trial, there were arrhythmia concerns at doses at 30 and over per day. When it comes to psychosis, this is obviously very distressing to the individual and also distressing to the family and others and the care system around them. So it's important that we treat the distress associated with the psychosis and not just the symptoms. So there are people who have benign hallucinations where the hallucinations are untroubling to them, and the family can be encouraged to cope with that. This might be I had one patient who had the experience of little nuns fluffing her pillows. That's a benign hallucination. It wasn't causing her distress nor the families, and we came to agreement to not use potentially dangerous drugs in that treatment. For agitation, as opposed to psychosis, antipsychotics have limited overall efficacy, and that's been looked at in double-blind placebo-controlled trials. And of course, many of us know that there is a black box warning in antipsychotic use because it increases the all-cause mortality by a hazard ratio of 1.6 to 1.7. So it's a small overall number, but the relative risk is significant. So non-pharmacologic approaches to minimizing problem behaviors. For sleep, we want to have someone have as much daytime activity as possible. Apathy is a symptom of Alzheimer's disease and other dementia syndromes. And so using behavioral management to increase activity and overcome the apathy is important. Sleep hygiene is a problem for most of us, and our people with dementia are no different. And minimizing drug use, especially over-the-counter sleeping agents that have diphenhydramine in them, because that can adversely affect cognition and lead to further disruption of the internal architecture of sleep. For purposeless activity like restless pacing or wandering, providing a purpose, folding laundry or other repetitive activities, sorting coins, they can be a good way of occupying the person's hands and reduce the purposeless activity. And I had one family who simply kept a basket of towels for grandma to fold, and whenever all the towels were folded, they would bring out another basket of similar towels and have her fold that one, and they could just keep a cycle going of them unfolding towels while grandma folded them. The purposeless behavior can also be used as a trigger for exercise. If a person is walking and pacing, get them out and do a walk, or recommend the family do that with them. And then for toileting issues, schedules are the optimal way of managing these. And we do want to minimize drug use, again, because of anticholinergic and sedative effects. So there is a bright future for treatment. Currently at review in the FDA is an agent called aducanumab. It has been through phase 3 trials. It's a monoclonal antibody that selectively targets the A-beta aggregates, including the soluble elements, as well as the insoluble fibrils that make up plaques. This is the results of their phase 2 study. And we see on the scans that over the course of a year, especially with high doses, there is a reduction in the amyloid signal over time. So in the left-hand panel is baseline and the right-hand panel is 1 year. And the brighter colors like the red indicate amyloid concentration. So we see a reduced amount of amyloid after 1 year of treatment on PET scan. Similarly, when looking at a global behavioral outcome, the CDR sum of boxes, which includes cognition and function, at 6 months of therapy, there was no discernible difference, but at 1 year, the high dose group had a significantly better sum of boxes than the placebo treated group, which means we have slowed decline. The emergence of effectiveness at 1 year versus 6 months is an evidence of disease modifying therapy, at least as I interpret it. Phase 3 data shows similar outcomes. This is a secondary outcome, the mini-mental state exam. The primary outcome in this analysis was that same sum of boxes, and it was also positive. But we're more likely to measure the mini-mental in an office setting, and the outcome was a 22% reduction in cognitive decline. So these antibodies that target A-beta aggregation reduce the amount of A-beta in the brain and are associated with what appears to be a slowing of progression of the pathology of the disease and the results of that pathology, the symptoms including memory loss and cognitive test scores. So there are some takeaways for the successful care of the person with dementia. The best dementia care is a team effort, and it's a collaboration across members of the healthcare team, the family, and the community. Primary care, as Carolyn has mentioned, is the core element of this team, that central relationship with the patient. Dementia specialty clinics can help with difficult diagnosis and management of unusual symptoms. But the common goal for all of us is to maintain the quality of life for the patient, the family, and our extended community. And case management services can become very important, especially when it exceeds our time availability as physicians or advanced practice providers. In that case, working with organizations like the Alzheimer's Association or local advocacy groups, and working with case management groups. But having someone at that focal point of the medical care, social work, and nursing in that case management sweet spot can often help families get their needs met in a very efficient manner. And as a health system, I think we as a group need to be looking at ways of improving access to case management quarterbacks for cases, especially as the symptoms exceed the capacity of what we can typically do in primary care or in the clinic setting. So I think at this point, we'll open things up for questions.
Thank you very much. That was a wonderful presentation. I want to remind you that this activity is supported by an independent educational grant from Biogen. Now, we do have some great questions that have come through, and I'd like to spend a little bit of time we have left with these questions. And I think the first one is probably Dr. Clevenger. This is a really daily issue. How do you manage the workflow of all that needs to be done in the diagnostic evaluation for MCI or early dementia in a busy primary care practice?
Yep, that one comes up quite a bit. And because it is fairly lengthy, you can see all of those elements that are required to get you to a reasonable, specific diagnosis. The way that we do this in our practice is that these are visits that are scheduled under we call them cognitive assessment visits, not very original. That is the name of the CPT code for 99483. It's a pretty reasonable amount of reimbursement for capturing all of these elements, most of which are assessment. And you don't have to use that visit only for the initial cognitive assessment. You can do that as an annual or as things change. We also make some of those pieces of information, the functional assessment, neuropsych inventory, and caregiver assessment, for example, as pre-visit questionnaires that are pushed out to patients or care partners in advance, makes the flow go much better. I spend ideally 60 minutes. That's a 60-minute appointment for us. It's a high level of medical decision-making that goes into that visit. I have done them in 40 minutes. And that seems to go just fine. You do need to allow some time. That code requires a written care plan as well. So just something to keep in mind. But CMS does reimburse for that level of work, which is very helpful for our primary care folks.
That's awesome. I have another question. I guess this sort of comes in, not surprisingly, many of our patients search Dr. Google for some of their problems, and they'll come to you and they'll ask about any preventative supplements or active supplements that you would recommend for those who have mild cognitive impairment or early dementia. Is there anything that you can deal with in what those patients may come and ask?
Sure, I'll take this one as well. So this does come up quite a bit, and even if patients aren't asking it, it comes at them. I think there are certainly target demographics for those types of direct-to-consumer advertisements. So in this case, this is more of, I don't have anything that I would say is a blanket recommendation. So years ago, we used to talk about doing high dose of vitamin E, and there were risks alongside that outweigh the benefit. For a time period, I was talking with folks about high dose vitamin B12. And similarly, that looks like there may be some risks in population cohort studies. And so really any supplementation is a direct treatment of something that they may be actually low in themselves. So if they are running low on vitamin D or they do have a low B12 level, we'll supplement that for that individual patient to get them up to normal levels because we're trying to optimize the environment. But I would not say there's a blanket recommendation. Most of the things that I see advertised or recommended, best case scenario, do nothing. Worst case scenario, interfere with medications or have other adverse effects that we don't know about.
Fantastic. And I don't know whether this is for David or not, but you mentioned that that an earlier start of cholinesterase inhibitor drugs has detectable benefits through at least 3 years of treatment. So is there a right time to stop these medications, or should you?
So there's really been very limited data on discontinuation studies. There are a few that have been published going back to the early days of the cholinesterase inhibitors right up through 2000. And what they show is that for a portion of the population, when the medication is stopped, that there is a clear-cut decline in cognition in the first 2 to 6 weeks after discontinuation. And it's typically noticeable. We published that back in 2002. But we don't have any good data on discontinuation after more than a year. So I recommend watching empirically. So if there's a sense that the person is progressing in a way they might if they had not been treated, a trial discontinuation to see if there's any acceleration of that course on stopping the medicine is worthwhile. If they do show decline within the first few weeks, that's a clear sign the medication was continuing to provide benefit and should be resumed, possibly through the usual dose titration. I think that was the take-home message of the earlier studies that looked at discontinuation early in the course of treatment.
Fabulous. Now, this sort of continues on the line of therapy. And I think one of the questions actually asked about reading something that just came out yesterday about plasma exchange with albumin replacement in Alzheimer's disease. And there's also some exciting news about the use of anti-amyloid antibody treatments for Alzheimer's disease. What can you say about these things, and where do you think they're going?
Sure. So earlier this year, in summer of 2020, there was a report on the amyloid replacement therapies that indicated it was a possibility that it could alter the course of progression of people with Alzheimer's disease. And that type of study continues. The idea that albumin itself may absorb some of the toxins that contribute to the progression of Alzheimer's disease, serum amyloid and things of that sort. And by refreshing the plasma, you can refresh that sink and perhaps delay progression. For the anti-amyloid therapies, one of those is now pending before the FDA for consideration of approval. In fact, that hearing is going to be just about a month from now. And so we may be on the horizon for anti-amyloid immunotherapies. Those have been developed now for over a decade, and we're finally getting to the point where we understand they may work. It does appear from the existing data, as I showed in my portion of the presentation, that earlier administration of those in the mild cognitive impairment phase may be more effective. And of course, we do have to worry about adverse effects with that as well. And one of the recurring adverse effects we see with the anti-amyloid therapies is the risk for cerebral edema, and even in some small proportion of cases, cerebral hemorrhages. They're microhemorrhages and small areas of edema, but that's still a considerable worry for some folks.
That's wonderful. You know, I think a question that comes up is whether it's even feasible to do genetic screening. I mean, if there's family history or the worry of Alzheimer's disease, is there anything in the practitioner can or should do or recommend as far as specific genetic tests to screen for early onset, for instance, mild cognitive impairment or even Alzheimer's disease?
So the question of genetic testing is mentioned in the newer clinical practice guidelines out with the Alzheimer's Association. And it's not something that's done early in that diagnostic process. So as you might have seen in the presentation, the volume of people who should be getting these additional layers of tests goes down, mostly as diagnostic uncertainty gets more, if it's still unclear after doing these usual tests, then you might do additional things. One thing about genetic testing is that it really should only be done in a context in which patients also have access to genetic counseling. And so, and none of the off-the-shelf kind of genetic testing that you see that people can send off on their own. Those are really not very helpful or specific. And so it may be that genetic testing is part of someone's overall diagnostic evaluation, but for most patients, it would not be.
Fabulous. I'm going to give it back to you. Is there anything else you'd like to say? Not looking much at any other specific questions, anything that you would like to have? We've got a couple of minutes left in questions. If there's either one of you would like to just let our audience know something else or a pearl that you may have for them.
So there's a question that often comes up about, what are the early clinical signs? What do you worry about, and how do we distinguish from aging? And one of the ways people often ask, well, I'm slow to recall a word, or I wanted to say something and it didn't come to me right away. Is that a sign of Alzheimer's or a sign of dementia? And it can be, but it's also a sign of aging. And there are many illnesses that could lead to delayed recall of words or delayed word finding in conversation. And so that's all part of the workup. Cerebrovascular disease can do it. Other degenerative diseases beside Alzheimer's disease can cause word finding. So it is something that needs to be attended to, but it's by no means a slam dunk that's part of the process of an Alzheimer's degeneration.
Fabulous. Well, I think we've run out of our time allotted for this session. I want to thank Dr. Clevenger and Dr. Geldmacher for their wonderful input, education, and participation in this question and answer session. It is time now for a 30-minute break. And after that, we'll see you back. And at that time, you'll have Dr. Cindy Cook will be your moderator for the rest of the sessions this afternoon. I thank you for allowing me to be a part of this early morning and afternoon session. Thank you.